Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. And today we're going to be talking about the OBGYN doctor shortage. And my guest today is Dr. Neel Shah. Dr. Shah is an OBGYN and Chief Medical Officer of Maven Clinic, the largest virtual clinic for women's and family health, and a visiting scientist at Harvard Medical School. He has been listed among the 40 smartest people in healthcare by Becker's Hospital Review. His work has been profiled by the New York Times, Good Morning America, and other outlets. And he has been featured in the documentaries Color of Care, produced by Oprah Winfrey, and Aftershock, which is currently streaming on Hulu. Dr. Shah has written more than 50 peer-reviewed academic papers and contributed to 4 books. He also serves on the advisory board of the National Institutes of Health, Office of Women's Health Research. Welcome, Neel.
Thank you, Kirti. Thanks for having me.
It's so nice to have you. You are the second man I have had on this podcast.
Okay, that's quite an honor. I think the other one was David, right? David Sable?
Yes, you know David too, right?
I do. I mean, if you were to pick somebody to be first, he's a good one. So
okay, good. You forgive me. I'm thinking of giving out plaques because it's a high honor. Okay, it's hard to get on this podcast if you're a man.
Understood.
So, was there anything you'd like to share about your background that I didn't get to share here? I mean, I don't know where you went to. Your training was actually. If you want to share that, and then anything else.
Yeah, sure. I mean, we can start with why it is that a man went into women's health if you want.
Sure.
I mean, to be honest, as a man in my 20s, when I made that decision during medical school and training, it was the last thing that I thought I was going to do. For me, I had a very unusual pathway into everything. The one predictable thing I did as an Indian kid from New Jersey is go to medical school. And then I think after that, every professional decision I made was a little bit unpredictable. But in the mid-aughts, I think they're called, 2006 or so, there was a candidate for president who was really inspiring to me and ran this amazing campaign, Affordability of Healthcare. It was Barack Obama, by the way, he won. And then I was really taken by this campaign and I interrupted medical school and to get engaged. And one of the things that I saw was that everything that policymakers were trying to do to improve healthcare was aimed at people over the age of 65. Because Medicare was the vehicle to get it done. And meanwhile, all of my friends and family were in the phase of life where they were starting and growing their families. And so that's what actually compelled me to pay attention more. So anyway, that's why I went into women's health, because if you care about people who are starting and building their families, women's health is the way to do it.
Right.
So I trained in Providence, which is a post-industrial New England city. And then I did all of my residency and all of that in Boston at Brigham and Women's and Mass General.
Okay, great. Thank you so much for sharing that. Yeah, I didn't realize you grew up in Jersey like me. I guess there's a lot of us.
There's a lot of Indian people in New Jersey. And, I at this point in my life, because I came up to Boston for all my training in school, I've lived most of my life here now, but I still identify as being from New Jersey.
Same with me. I live in New England as well. And I guess I've spent more years up here now. But I think there's just something if Jersey is just in my blood too.
Well, it's I don't know if this was your story, but a lot of my family, my parents came over on an H-1B visa. Nobody knew what that was until a few weeks ago.
Mm-hmm.
They came in the 70s and then they landed in Queens, Jackson Heights, a lot of my family. And then they kind of fanned out to Long Island and New Jersey once they were starting their families. So there's a whole immigrant, striving culture that comes from New Jersey. And even when I think about, reproductive health and maternal health in New Jersey, there's that's the lens I see it through. It's something like 40% of the people who give birth in New Jersey are immigrants still today in
Oh, I didn't
2025.
realize that.
Yeah.
Amazing.
And so like I look at the stats in New Jersey, which are not great. And like that
Yeah.
feels, it was my family's story too. So
Yes, yes. I was very much influenced by, I think, our culture too, just very much family focused. So it makes a lot of sense. In your bio, I actually did want to hear a little bit about these documentaries. I didn't realize you were involved in these documentaries.
I was. So, I mean, these both came out and were filmed during the pandemic. One, The Color of Care, was produced by Oprah with the Smithsonian Channel, and Gans Ford was the director, who is a very well-known director in producing. He was nominated for an Oscar, I believe, for his first documentary. It was much more of a explainer of inequity during the pandemic, where I was filmed as sort of like a talking head. And to be honest, it's a very unflinching view of what was happening during the darkest days of the pandemic, and it's kind of hard to watch, to be honest,
Oh,
because
wow.
even now it's like hard to go back to. Aftershock is a very different kind of documentary. It's also filmed during the pandemic. It centers two families who lost a loved one in childbirth. And then that happens in the first 10 minutes of the movie. And then it follows the families longitudinally and what happens to them and how they kind of activate their communities and advocate for change. And that one I think is easier to watch in some ways. Both are really great films, but the second one I think is really inspiring because you see the power of using your voice, especially during times where it feels hard to feel like you can make a change. It's a really, really powerful documentary. And I got involved in the first one, like I said, like a subject matter expert. Like they contacted me, and in both cases, I didn't expect to be in front of the camera. I thought I was going to help on background. But in the second one, especially, I ended up kind of befriending one of the families and then coming into the film like kind of organically. And then I also became a subject matter expert on the film.
Well,
Yeah.
thank you
So
so
anyway,
much. Yeah,
that's the
I just
long.
learned about it and I'm going to watch them now.
You
So
should watch
thank you very
Aftershock.
much.
It's on Hulu. It's excellent. It won the Impact Award at Sundance. It got nominated for an Emmy. It won a Peabody Award. It's like a really, really great, powerful film.
Okay, great. I will. Thank you. All right. So, why I wanted to talk about this topic. Obviously, it's a big problem and only seems to be getting worse. I wrote down a couple stats to introduce the topic. So it's let's see. I've read that more than a third of US counties, especially in rural areas, lack an OBGYN provider or a birthing center. And that affects nearly 7 million women in the US. And the American College of OBGYN has stated that there's a current shortage of about 8,000 OBGYNs, and it predicts that shortage is going to be at around 22,000 by 2050 if these trends continue. So I thought we'd start about why this is happening. What do you think are the biggest factors contributing to this?
I think the statistics that you just highlighted kind of reflect two realities. One is that we don't have enough OBGYNs, period. There's a supply issue. And then the second is that OBGYNs are not distributed across the country in a way that fully reflects the need out there. Like to your point on rural families, like, I think 80% of the US landmass is rural. It's like most of the country.
Yeah.
But, I think it's 1 in 5 families because we have a lot of families concentrated in cities. But there are parts of our country where you have to drive farther than 3 hours to get to a facility that's qualified to take care of you during birth. And that's farther than you have to drive from any point in Kenya to a birthing facility. But that's what it looks like,
Okay.
in like the heartland of the US right now.
Mm-hmm.
And again, so there's sort of like different reasons for the different issues. I think, we can talk about the supply issue and what we can do to get more people to go into OBGYN and to produce more OBGYNs. But I think the distribution problem is almost as important. And that really is a reflection of, one, we don't pay for what we value in healthcare. Like childbirth is the most utilized service, period. 25% of all hospitalizations are a mom or a baby. But for most hospitals, it's a money losing enterprise to be in the business of delivering babies. So if you're a rural hospital, you only see a few deliveries per year or even a few hundred deliveries a year, you're going to lose money.
Yeah, it's so insane. I just remember, I mean, we've all seen these little community hospitals shut down. Even, I mean, we're in a coastal state, and we see this. And so, I mean, even in in Massachusetts, which you would not think is rural, we have, gaps in care and
You see the same
access.
thing. Like in Washington, D.C., it's the same thing. There are, it's a challenge that impacts rural America, but it's also a problem that impacts urban America. Like, Ward 8 of Washington, D.C., you might have to take 3 city buses to get to a birthing facility. So from a travel perspective, it could be the same thing.
Mm-hmm. Yeah. And to your point about, we're not paying for what we value. We're not prioritizing women's health. And I still remember some of the discussions at these little hospitals. I've worked at a couple that have shut down. And the discussion was like, where women go for care is what draws all the other, the other family members in, right? And other health helps build the services in other specialties. So it was so important to focus on offering this care, but they frankly couldn't afford it,
But
and then
here's the
that
thing,
just,
is like the way that you just described it is true, but it also positions providing childbirth services as a means to another end.
right.
So
Well, that's how it was framed. The discussion was
and
framed.
that's where it falls
Right.
apart. You
Right.
live in Boston, I live in Boston. Mass General Hospital is a well-known hospital in our city.
Mm-hmm.
And their hospital that's 200 and something years old. And they didn't have a labor and delivery unit until 1994. And the reason was 1994 is when managed care first really became a thing. And they were like, well, labor and delivery is the front door to the hospital. So it's worthwhile to invest here because we'll
Mm-hmm.
be able to quote unquote capture people later on. The complexity, though, is that usually for most hospitals in America, you don't start to make money, meaning you don't start to make more money than you're losing until you're delivering thousands of babies per year. But most Americans are born at hospitals that deliver way fewer. Anyway, the cost accounting of healthcare is a whole other thing. But the cardiac ICU has all the same costs as the labor unit, but gets paid way more for care than the labor floor does. And I think that's actually the root cause of the problem.
I think you're right. Why are reimbursements for OBGYN care so low, And I think that reflects the sexism in society and medicine,
It does. Yeah, unquestionably. It's also neither the cardiac ICU nor the labor floor should cost so much. So we can talk about how we can make them cost less. But yeah, no, fundamentally, we've always taken childbirth and women's health more broadly for granted. Because it's funny, the fact that everybody is born, you would think would garner more empathy, but it actually makes us less empathetic. The fact that it's a universal experience, we just sort of take it for granted.
Right. And so such a fundamentally important part of society. We should prioritize it above a lot of other things that we think are more important. We seem to fund more. So yeah, and I think because these reimbursements are so low and OBGYN as specialty, I mean, frankly, I don't think it's respected, at least not in terms of pay, for example, as other specialties. And so it makes it less appealing too, right? To future doctors. And that doesn't help draw people to the field either.
Possibly. I mean, there are definitely specialties in medicine where the lifestyle is easier and you get paid more. And let's be honest, I think, OBGYN, especially as you practice as a generalist, it's a very broad discipline that has like sort of a classic surgical discipline. We're also expected to be primary care doctors. And then there's obstetrics, which is probably one of the oldest health professions that grows out of midwifery, and it's like all of that responsibility together. You sort of live in this liminal space between primary healthcare and specialty healthcare. And then you have a brutal lifestyle because you have to take call. You have to take usually 24-hour call pretty often. You give up your nights, your weekends, and it's a lot. And by the same token, one of the things that made it a relatively easy decision to go into OBGYN as one of the very few men that were making that decision is that it's a very, very mission-driven field in a way that's very different from every other specialty. It's not that general surgeons don't care about social justice, but when you're taking out a gallbladder, it's not the same thing as caring for people's reproductive health.
Absolutely. It's true. I very much feel that. I felt it just more and more over time. Just, it's more than just a job, right? You you feel very much like you're doing good in the world and helping people in need. There, and I agree, like it's such a broad specialty. I do feel like now with the primary care shortage, I feel like I'm doing a lot more primary care things as well, refilling prescriptions, doing lab work that usually primary cares just do. And so, yeah, we're filling that gap. And I do think it's kind of a lot for one specialty to do, you
It's a
know?
lot. Like, I always think about this, that a bad system will beat a good person every time, and like the OBGYN, you know, your hands still matter in OBGYN. There's no, like, you'll never deliver a baby through a screen. There's no like button to push for a lot of the routine bread and butter things you do in
Right.
OBGYN.
Right.
Whereas there's other specialties of medicine where increasingly that is the case. Even like primary care, the best of primary care is a set of capabilities and it requires a lot of sophistication and nuance. But a lot of like bedside diagnostics today is becoming more obsolete, but in obstetrics, it's not the case. And I was sort of drawn to the fact that it requires you to be like the best kind of doctor, right? You have to build these longitudinal relationships. You have to be willing to deal with acuity and jump into the operating room on a dime. It requires all these things of you. And so like that's my pitch to anybody listening on the fence is like, I think OBGYN is sort of like the best of medicine in a way, but the system to the point is a bad system will beat a good person every day. So that's
Yes,
what's
I agree. That definitely influenced my decision to go into it because I do like that feeling that we're a little bit of jack of all trades. You get to, and whatever you're really interested in, it's there, like if you wanted to do some surgery, if you love following patients throughout their lifetime, you know, delivering babies. I mean, there's no bigger high in medicine, I think. Hopefully, so this will attract more people to the field. I also wanted to point out, yeah, like the other thing is like something you mentioned, there is a high rate of burnout, right? I mean, because there's a shortage and the demand is just so much more than the supply of doctors or the hours we have. So I think, and another point is we also have all these subspecialties in OBGYN that are also short providers, right? So I just think there's not enough slots at all for what we do. We're literally caring for 50% of the population. Why are there so few slots, residency slots, for example,
Yeah, I think that we should be doing a lot more across the whole pipeline to get more qualified people in women's health, which is why I had to sneak in the pitch for OBGYN into my
Yes.
response. We need more people joining the ranks, and we will not just fix it with more bodies and more people. A lot of the challenges that we face are truly systemic and structural, especially when we think about, our work is right at the intersection of gender inequity, racial inequity, geographic inequity, to our point of rural Americans, and even like generational inequity. When we think about the moment that we're living in right now, I think is best explained by a failure of governance to be responsive to people who are in this phase of life. The younger, like build back better, make America great again. Like all those slogans are about this idea of generational inequity. Like
Right.
it's actually more dangerous and less affordable to start a family today than it was a
Mm-hmm.
generation ago, like objectively. And so,
Yes. Yes.
like, yes, we need more people going to OBGYN. And the reason to do it is because you're mission driven, because you're proud of the fact that you're the best doctor you can be and you're capable of doing all these things. And we really need to be thoughtful about how the system and the structure gets evolved to take care of half of our population. And by proxy, the rest of the population too, because we're all born.
Right, right. I know there's a discourse about, birth rate crisis, right? That you sometimes see the right wing discuss, but exactly, it's just dangerous, frankly dangerous right now to have a child and be pregnant with, rising rates of, morbidity and mortality being for moms. And also you frankly can't afford it, right? People are living paycheck to paycheck. It's actually, you risk your livelihood just having a child.
Yeah. I mean, I wish that it wasn't an issue that was championed by one sort of political perspective or another. Like, I think that we should be having a collective conversation about the fact that empirically it's less affordable to have a child. It's empirically more dangerous. Fertility rates are declining. All those things are probably related.
Right.
And that has major implications for our country and for our society. So, I would love people across the political spectrum to engage and, and to really frame a lot of the broader issues in terms of the needs of people who are growing their families, because I really think that they're a bellwether for the well-being of society as a whole. Like, if moms are unwell, society is unwell. Society is unwell, moms are unwell.
Absolutely. Okay, so we talked about some of the problems that the shortage is causing, definitely access issues throughout the country, delayed care. And I think delaying care often just makes, patients have higher severity of problems. And then they're going to be more expensive and harder to treat and probably have even worse outcomes. We talked about the mortality rates increasing, morbidity increasing. I also think it's affecting preventative care. I know, like if you can't get in for an appointment to get your pap done, for example, you're delaying diagnosis of cervical cancer. And then birth control. So where else do you see this is affecting? What else do you think it's affecting?
I mean, it's affecting everything. Point. I mean, you made a pretty good list, but I also think it speaks to maybe the disconnect. This is my point of view on this. Is like, I think that the incumbent healthcare system, which is an intentional label, that's like the one that I practiced in for my whole career. It's brick and mortar. It requires containing healthcare within a four-wall clinic. I think that it is increasingly not only failing to meet the needs of people, but it's actually out of touch with the way people are actually seeking out support, which is creating an ecosystem in which there's an alternative to the incumbent system that's being built. And ideally, there's a world in which they converge because you can't deliver a baby through a screen. But the thing is, like, those systems will always struggle to reliably show up for people when they need and expect them to, forever. Like we saw it during the pandemic when it was particularly strained, and we saw people delay care because we told them to, and we saw the consequences of that. But we also saw, a combination of phenomenon. One was digital health becoming more normative. We're like, oh, maybe you don't have to come in 14 times for prenatal visits. Maybe like a century later, we're going to rethink that and be like, maybe it's not 14. Maybe we can do some of it checking in virtually. We also saw people changing where they go to access healthcare information, not going through official channels, but going to TikTok. Because not because they're not intelligent, but because TikTok is more affirming than our profession has been for them for a long time.
Yeah, that's unfortunate. I mean, I agree. I think so much of our day-to-day life now is becoming digital. Like even you and I mean, we're in the same state, but we're meeting virtually. It's just easier. So to your point, I think there's things that we can move to that digital realm to increase access. But of course, the thing, like you mentioned, deliveries, we can't. Pap smears right now, we can't. So what types of care do you think we can offer virtually?
I think of it as a Venn diagram, Kirti. So there's like, things that you can only do in person. There are things that you can do in person or virtually, which are like, aspects of the routine prenatal visit, maybe, or a consultation for something, But then there are the things that you can only do digitally that you'll actually never be able to do in person. And those are some of the most interesting things to me. Like, for example, I'm the chief medical officer of Maven Clinic. We're, working at large scale. And one of the capabilities we've created is the ability to connect with a doctor or some other kind of clinical expert within an hour, any time of day, no matter where you are. And by the way, they can speak your language. They have some kind of identity-based affinity, which is important to a lot of people. So like if you're a Black person, you can connect with a Black mental health provider. That's a capability that's almost impossible to replicate in person because you're constrained by time and space. And it's particularly important when we think about like rural America. Like we serve a Medicaid plan in Arkansas. And if you're caring for someone with gestational diabetes in the Delta region of Arkansas, they don't have a proximate nutritionist. That's just not a thing. And there's a big difference between scheduling an appointment with somebody like weeks out and on demand, being able to have somebody look through your phone at your refrigerator as you're planning a meal when you're trying to radically change your diet, right? That can be the difference between a preterm delivery and not. So I'm most excited about some of the capabilities that actually take things that we've kind of conventionally always assumed have to happen in the clinic and, build them in new ways.
Yeah, that's really interesting to hear. So I didn't realize that. Okay, so you offer, what kind of OBGYN services do you offer? You mentioned mental health and nutritionists consults, for example. What else?
So we have 30 plus specialties within our virtual network of providers. We also, so let me step back and explain Maven a little bit. So Maven is a virtual clinic. We do not deliver babies through a screen. We primarily provide virtual care management. We also act as the payer for fertility primarily, but also for doula reimbursements and other things that don't neatly fit into a health plan construct. Excuse me. I don't normally sound like Kermit, by the way. It's just I've got a cold. And we care for people who are anywhere from being pre-contemplative about starting a family through fertility, pregnancy, parenting, and pediatrics, and all the way through menopause. I always say that we're not a condition-based company. We're not a pregnancy company or diabetes company. We're a phase of life company. And so our job is to care for people during the phase of life where they're building a family or going through like a midlife menopause transition or parenting journey, for example. And so we're not treating people as like a uterus and a set of ovaries. We are experts in the context of their lives when they're trying to build a family. And then we deploy clinical capability around that context, which is totally different. So just to give you an example, like we know that health is not produced in our clinic. It's produced in people's homes and in their workplaces and in their communities. So like one aspect of that, as we were speaking to, is just to be able to reach them. Right? Like imagine trying to talk to a doctor in 2025. You would have to call them on the phone and follow up, and it's a huge pain. But if a friend or family member of yours, Kirti, like has a question, they can just text you and you will text them back. You don't have their EMR, but you can tell them something that will help them. It will reassure them or it will directionally help them. And we give that capability we cover 17 million lives. So a lot of people. And we work by contracting with anyone who purchases healthcare in bulk. So we have 2,000 clients, and they include everyone from the largest employer in the world who has a baby every 18 minutes through Medicaid plans, unions, you name it.
Okay, so I can see how this is really helpful to fill in the gaps where there's so much demand and not enough providers. But I guess my questions are, well, what happens when someone does conceive and becomes pregnant and needs in-person care? How do they transition from this virtual care to that?
That's a good question. We are filling in the gaps. Also, in my mind, because gap filler makes it feel like we're just in the interstitial space. But I think everything that happens outside of a punctuated 15-minute visit is the actual space.
Good point.
Right? Because people live most of their lives. Right. Right. And so I appreciate this so much now, but as clinicians, we'll give people advice, but we don't always tell people like how to go about changing their diet or exercising or adhering to a complex medical protocol. So I think the rest of it is actually the work. And that's what I'm really interested in. But you do need the in-person doctor. So in fertility, we are contracted with a fertility doctor network. And so we take a population of people who are trying to conceive. It turns out some people get pregnant easily. Some people commit themselves to IVF. And most people are somewhere in between. Nobody's out there shopping for a coach to help them conceive. But when you offer it to people, they opt in at rates of 90%, which is amazing. And then you help them. Right? Everything from the basics of cycle tracking through deploying at-home semen analysis tests which is,
I didn't
something.
know that was a thing.
It
Okay.
is a thing. Yeah. So like, I think that here's a hot take. I think every man should have a screening semen analysis.
I mean, the
It,
rates are rising for
it's
male
not just for
infertility.
infertility. It turns out it's probably a better biomarker than cholesterol. It's very sensitive to metabolic health. It's very sensitive
Oh,
to toxic exposures. And so on the margin, like this is a great way to get men to quit smoking, to not eat donuts. There's a man on our platform who said that their sperm went from a graveyard to a rave just by changing their diet. You know, so
that's
anyway,
really fascinating to me because you know what? I have had chat with girlfriends about women just, for example, are regularly getting screened for STDs because they just see their gynecologist regularly. But men don't seem to have a doctor like that, you know, to see for, I mean, maybe a family practice doctor, but they're not regularly seeing someone for male health and fertility health.
my take on this is like women have a monthly cyclical event that almost acts as a check engine light, when something's
Yeah,
up. And
that's
it turns
true.
out men do, it's just hidden. Like men regenerate sperm every 30 to 60 days. And again, it's very sensitive to like things that we're all trying to get people to do to be healthier. But even to take a big step back, men's health is an important part of women's health because women end up becoming treatment surrogates for what are male issues, like
Oh,
a lot,
yes.
a lot.
Yes. And
Infertility,
their
but it's,
therapists and their
yes,
nutritionists and
totally,
remind, right? So
totally.
absolutely.
So yeah, we work with the in-person doc though, to just answer your question directly. We refer people into a high quality doctor and then we coordinate around the care sort of as needed.
Okay. So I love this idea. Like, you mentioned that you're contracted with employers and other health plan providers. I mean, so you basically take insurance. It's not more. It's covered by insurance.
It's free to the end user. And
Okay.
then it's paid for typically by whoever's purchasing the healthcare services. So it could be the health insurance for like fully insured. These are things like, it's really wonky that I didn't even realize until I was in this job about how our health insurance industry works. But basically, yes, it's typically like offered, let's say like an employer benefit. And the employer
Mhm.
will pay like a flat rate for every employee that enrolls in Maven. And then by the way, the expectation is that we return that in value at least 2x. So for every pregnant person that enrolls in Maven, I have to save an employer twice as much through preventing a NICU admission, preventing a C-section that need to happen, supporting somebody's mental health. I don't want to be compared with a standard health plan because I think that what we're trying to do is different
Better. Yeah.
and better. I think it's better. Let's say it's
Okay.
better.
Well, okay. So here's a question for you that it's not exactly on our topic, but I'm one of these universal healthcare people. Like, I'd like to see that. Do you feel that what you're doing here needs to have the private insurance, private insurer, or employer sponsored insurer? Or do you think could you imagine it being integrated in? I know it's a far off fantasy to imagine that we'll have
A single payer.
Medicare, yeah, single payer.
Listen, I taught intro to health policy to first year medical students for like a decade. And there is a class where we would compare different health systems. And there's not a health system in the world that's perfect. And they all have trade-offs. Like if you're in, I almost don't want to use the NHS as an example right now because under such strain, which is
Mhm.
kind of the case in point. But if you're in like a socialized democracy in Western Europe and you're the average person, that system will be much more responsive to your needs because it's designed for the on average person. But if you have something rare or unusual, you're way better off in the US, even though we have a very uncoordinated, fragmented system. Like there's no world in which I believe like an MD Anderson or a Sloan Kettering would exist in outside of
In
the US
socialized
approach.
medicine.
Well, let's not even say socialized, but say like the US
Oh,
context. And then there's something about the ability of localization to be responsive. So I do think that the private sector, or at least, you know, a more regional approach to certain aspects of healthcare could be better for coverage. But
no, that's
there are a lot of people that are left out of the system, and the single payer system is another way of building toward.
Yes. I know that there's places, yeah, that's a good answer. I think I see what you're saying. There's benefits and disadvantages with each, but I almost could see you could pay, maybe there could also be a pay, there could be a base, and then you can pay additionally. Your employer can pay
I
additionally,
agree.
perhaps for another tier.
I think it is unacceptable to live in a country where people have to choose between their life and their life savings routinely. I think it's absolutely unacceptable. And I think that, ideally insurance is for what insurance is for, which is covering us during a catastrophic event. But unfortunately, health insurance has evolved to be something else, which is a subsidy for the equally unacceptable prices in healthcare that are inflating by like 10% year over year, which is another problem. What I worry about is an approach that's like, let's take the current system and not fix it, but just spread around coverage within the system. And then that just incentivizes everybody to keep on ratcheting up prices. So that's why I have a more nuanced perspective, but I fully agree with that. I'm a doctor. The idea that I have to see people who need essential things, and then it's like, they've got to choose between their rent and getting a colonoscopy. That was the world we lived in 15 years, which we absolutely should not return to.
Right. I have that thought often, like, what's the point of health insurance if my patient is declining some tests because it's going to be too much out of pocket, So, okay. So back to the problem at hand. You talked about, or the topic at hand, you mentioned this virtual care as a possible solution. What other thoughts do you have about how to improve this OBGYN shortage? I know something I wanted to talk about is our policies currently and how
there you go.
Making it worse. Yes. Of course, Roe being overturned is a big problem, but also wasn't there recent news about this Medicaid interruption, Medicaid funding?
None of that helps. No, I think, I think that in the current context, there is a lot of uncertainty on top of a lot of regression when it comes to reproductive health and reproductive health care. Overturning of Roe v. Wade was obviously really dangerous and really damaging for a lot of people, and not only for abortion care, but also for access and supply. Like we talked about how, we need more OBGYNs. We also need a different distribution of OBGYNs across our country. In states like Idaho, I've talked to colleagues where it's untenable for them to continue practicing because, as the law is still being interpreted in real time, and there are routine things that we deal with in the ER all the time that are required for saving people's lives. And there are a lot of OBGYNs leaving places like Oklahoma and Idaho and Iowa and the Southeast, and that's a real problem. So I agree, we need policies, and I'm worried about a world in which there are further cuts to Medicaid, or we do things that make it harder for people to access Medicaid. Medicaid pays for half of the births in our country. That in and of itself is an indictment of our country, given that Medicaid is designed to help the poor. And 40% of pregnancies are paid for that way. Again, if society is unwell, moms are unwell, and vice versa. And, a world in which people have to jump through more hoops to get access to that essential coverage is also deeply concerning. So policy plays a role, but policy is also a blunt instrument. Policy can fund and regulate. And underneath that, we have to figure out how to build services and products differently. I think actually one of the biggest opportunities we have, it's not just virtual care. It's how do we take really cost or human intensive services today in healthcare and in women's health and productize them so that they're more accessible. I mean, that's kind of like what every other industry does, except for ours.
Right. We're definitely lacking some creative solutions. I mean, people aren't funding, frankly, women's health enough, not just research, but, studying models like this, or other alternatives. So
yes, and let me be frank, I most of my colleagues are researchers. It's a lot of my personal social network today. I advised the NIH for many years. I also think that the leading cause of suffering for women in 2025 is not lack of knowledge. We can always use more knowledge, but it's actually the biggest cause of suffering is lack of execution on the knowledge we already have.
Mm, okay, interesting. Yeah, agree. So, okay, another big problem is, we already have a shortage of doctors, and I think a lot of the doctors experience a lot of burnout. We kind of talked about how much we have to do as OBGYNs and a lot retiring early. We have more older physicians versus younger physicians. So I guess I have some thoughts because of just from my own experience in my career, but what are your thoughts on how we can make it a specialty where we can enjoy more and not burn out so much and have longer careers and not be trying to retire early. So,
first of all, thank you for the way you're using your voice and your platform to talk about things like this. We have not met in person yet, but we've been connected on social media for a very long time. I don't even know how long, possibly, I don't know. And I've always appreciated that about you. But I think it's Don Berwick who first brought this to my attention. Like burnout is not caused by hard work. It's caused by what he called moral injury, which is this idea that we talked about how in theory, conceptually, OBGYN should be like the best of us as a specialty. But what you come to work hoping you can do and what you actually get to do end up becoming two different things. And so you burn out, and how do we get better alignment between the actual processes of our day-to-day work in OBGYN and what we think our purpose in OBGYN is? If they're disconnected, people will burn out and they will leave. If they're aligned, they won't, even when it's hard, even when they don't get paid that much, honestly. I don't necessarily think that paying OBGYNs more is like our silver bullet here. I think it's people are willing to do noble things. Not that they shouldn't get paid more, but the bigger thing is the job feels misaligned with our values sometimes.
I very much believe that most people that go into medicine are not going into it for the money or the status. You have to really care about human beings. So, yeah, I agree with you. That's what I find it a very satisfying career to take care of people. And I think that is, when you don't have enough time to spend with people and when you're feeling like you have to, cut corners or not be able to get reimbursement for a test that you feel very that is very important for a patient or et cetera, then yes, that I love that term, that moral injury is going to build, right? You don't feel like you're doing your best. So, yeah. And I think, so my thoughts on it personally, I feel like people need balance. I think this is another problem. This field is very much a lot more women now. I think I read somewhere that it's 82% now of residency trainees are women, going into the field. And we don't have enough support for families in this country, right? And as soon as I had kids, I went part-time and I pretty much worked part-time my whole career and, after kids. And I think that's helped me have the balance to enjoy work, right? Because I'm not feeling like I'm shortchanging the family, right? So, but I think that, so we don't, if only, and I think a lot of women in other fields, not just OBGYN, right? Women workers have a hard time balancing career and family. And then you're going to be more prone to burnout, right?
I think that's exactly right. I remember, this is kind of a confession, but, residency, you work 80 hours, theoretically, probably more a week. You work a lot in residency. And then for me, I went from residency to an academic OBGYN job where, I would have a clinic and a call. But then in between, I was doing research and doing a lot of other things. And I remember thinking I would spend just as much time in clinic as I needed to remember I liked my job again. And then I would spend just as much time away from it as I needed to remember I liked it and then come back. Whereas nothing's fun 80 hours a week, especially when you're trying to have a family and unplug and, even if there's something that you deeply, deeply are passionate about, if it's all you have time for, it stops being fun.
Yes. Actually, that reminded me, like I broke my hip a few years ago and I was at home and for a lot of weeks and I didn't enjoy it. Like it's kind of funny.
Yeah.
I feel like you need a little of both to appreciate each, right? I ended up watching too much CNN and like going crazy. Like I did not like it being on the
Yeah.
couch.
Yeah. No,
um,
fair enough. No, there's the right amount of everything. So
yes.
I think
So
patients will serve when doctors get a little bit of balance too. So
yes, absolutely, definitely. So, another big problem, that adds maybe to the moral injury. Maybe I'm using it wrong, you can tell me, but might be, OBGYN's concerns about malpractice and medical, liability. We're one of the specialties where that gets sued the most. So I don't know. I guess I'm throwing in my 2 cents. I'd like to see I know we've been talking about tort reform for years and it never happens, but it's just very expensive even to pay for malpractice insurance.
no,
And
it's tough.
then
We ask a lot from people on the front lines of healthcare, and then OB/GYN is particularly litigious, and the idea that something, I think I'm pretty sure the statute of limitations is like the full 18 years for a child. So you could deliver a baby and then get sued 18 years later or something like that.
yes.
And if you're an OB/GYN, you're basically guaranteed to get sued at least once, probably multiple times over the course of your career. And yeah, it's enormously stressful.
Mm-hmm, mm-hmm. Oh, well, I wanted to add another creative solution. So this is another maybe pitch to medical students thinking about a career in OBGYN. One thing I can say, because we have the shortage, is that I feel like there is a lot of opportunity for creative solutions, like what you're describing, you do at Maven Clinic, but also another thing I did for a number of years when my children were little was become a laborist. So I just worked a couple of weekends a month. I'd stay over and do all the deliveries and cover the ER. And during the weekdays, I got to feel like a stay-at-home mom in a way. And this was before they started school. So I think that's kind of nice about it. Like it is because it's a field with so many women that there have been people trying to create, offer creative solutions and more support. So
I agree with that for sure.
So, okay, we're winding down. I did get one audience question, which maybe not totally on topic, but well, it is and it isn't also. So, this is from Nancy P. She says, it was very hard for me to find a GYN that would consider administering an anesthetic for colposcopy. I had to drive 3 hours to get one. She was amazing and did a couple of lidocaine injections and prescribed Ativan for my procedure anxiety. So I guess this is just a comment, but do you have any thoughts about what she's shared?
I'm sorry that she had that experience, I guess, is my thought. I know that our field has generally been, this is like a one example of many in which we do a disservice to everybody by dismissing people's concerns. And it's part of like this trend towards people looking for affirmation elsewhere. Like it's not that, our patients are going to TikTok because they don't know better. It's because we've lost their trust. And that's an example of, like it's not a big deal, lidocaine and Ativan. It's really neat person. It's probably the right thing to do, not just for her, but for everybody, to be honest. Like we're learning about IUDs. And, I didn't think twice about putting IUDs without anesthesia, to be honest, for most of my career. And now there's really good evidence that it's probably what we should do. It's very reasonable. It would make it more comfortable for everybody. Why didn't we just listen,
Yes. We didn't train to do these things, to do colposcopy or put in IUDs with this available, but it should be offered. It should be offered in training, during training, so people see how to offer it. And I think what you asked for and received is very reasonable. And most all OBGYNs have access to prescribing, should be able to prescribe Ativan and give lidocaine injections in the office. So I'm glad you found somebody, and it shouldn't have to be a 3-hour drive. So that's unfortunate. Okay, well, Neel, this has been really fun. Do you have any other thoughts to add? Was there anything that I didn't get to ask you about that you wanted to share?
No, I don't think so. Thank you for letting me be the second man on the Gynarchy
I'm going to give out plaques. Yeah.
Yeah. No, I know. I realize that's a big honor, and it feels like it is. Again, I just really appreciate using your platform and your voice in the way that you are. So.
Thank you so much. Yeah, it is. I'm very thoughtful about who I invite. You're top tier because, I don't want to end up like Oprah and, having invited like Dr. Phil
Yeah.
and Dr. Oz.
Yeah.
So anyway, let's see. Do you have any other, what are your future plans? What else are you working on? And,
I've got one plug. Okay. So I don't have a podcast. I'm not quite as good at being a podcast host as Kirti, but I do have a Substack, which is more my style because it lets me be a little bit like nerdy and cerebral, and it comes out every 2 weeks. So one, if you're a nuanced thinker, which you are because you're listening to this podcast, shout out to Substack in general. As social media has become a dumpster fire, Substack is not. It is a place for thoughtful, nuanced engagement. I love it there. So I highly recommend it. And then I have one called The Preprint, which I write every 2 weeks or so, where we do a deep dive into some topic and we do some reporting and talk to smart people. But I'm an introvert, so I don't have to do it through a podcast. I can do it in my introverted way. So.
Great. Thank you so much. And what about, do you use any social media that you want to plug?
I think that's the main one officially. These days, I don't even know. I think we met through my social media presence originally, but I don't know about most of those platforms. I think, to be honest, most of my professional outlets these days are Substack and LinkedIn. So,
okay. So we can just plug in your name and find you there.
In either of those places, and I'm happy to talk to anybody who wants to engage on these topics.
Great. And then what's the website for your company?
Mavenclinic.com.
Okay, great. Okay, so I like to leave with a closing thought. So I'm going to do that before we sign off. So in the patriarchy, women are devalued. And for that reason, women's health and women's healthcare providers are devalued. And this, frankly, puts women's lives at risk. In the Gynarchy, we oppose the systemic sexism we see in society and in medicine and seek to prioritize women's health. One of the ways is to prioritize women's health education, training of future women's health providers, and providing them the support that they need. So down with the patriarchy and up with the Gynarchy. Thank you so much, Neel, for your time.
Thank you, Kirti.
Did you enjoy this episode of the Gynarchy Podcast? Know someone else who might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Blue Sky, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.